أبنائي الأعزاء، السلام عليكم ورحمة الله وبركاته. آه، اليوم هنتكلم على blood supply of the heart اللي هو coronary circulations to the heart muscle, both arterial and venous blood supply to the heart. You know, the heart is having, generally speaking, uh, two arteries, mainly two arteries, the right and left coronary arteries. And for the venous drainage, we are having the main uh, sinus or drainage of the heart is the coronary sinus. And the coronary sinus is having most of the tributaries of the venous drainage to the heart, apart from just a small venous drainage from the atria itself or to the right atrium directly. Let us have those two diagrams which that are illustrating both the arterial to the left and venous to the right. The arterial is mainly, as we can see, both right and left coronary arteries are arising from the ascending aorta just after coming from the left ventricle, uh, just say above the uh, bicasp, the aortic valve, through what is known as aortic sinuses. And we are having two aortic sinuses, anterior and posterior. We shall come to that later on. To the venous side, on the right side here, we are having the coronary sinus, which is with its tributaries, really. There's a drainage to the coronary sinus, which is draining ultimately to the right atrium. The dark one are the anterior ones, and the shadow ones are with the posterior ones, just to have the complete picture. You know, it's important to have this picture in mind. So, as in the coming lectures, we shall use those illustrating diagrams just to keep them in the mind whenever we are talking about blood supply of the heart, whether arterial or venous. Coming to the arterial blood supply, and we call it in Arabic الشرايين التاجية. Those are very important, by the way. And when we are talking about arterial or coronary blood supply to the heart, we are talking about, you know, the very important disease in the heart, which is decrease or cut of the blood supply, what is known as myocardial infarction or anginal pain, which could occur to some of the patients liable to have heart diseases. So the right and left coronary arteries both arise from the ascending aorta immediately above the aortic valve. The coronary arteries and their major branches are distributed over the surface of the heart lying within the subepicardial connective tissue. We know the layers of the heart are having epicardium, myocardium, and endocardium. So the arterial blood supply are within just subepicardial in the subepicardial plane, and it has been harbored in between some sort of connective tissue so as to keep it in a place, and through that it gives its blood supply to the heart wall and related structures. Coming to details of those structures, let us have this diagram on the inset on the uppermost, on the right side, the, the, the heart and arterial blood supply. The dark ones, as I said, it is the anterior ones, and the shadowed one are the posterior ones. So the right coronary artery arises from the anterior aortic sinus. As we have said, we are both sinuses, and by sinuses meant something like intifakh, just coming up from just after the aortic valve, we are having this sinus, just some sort of tajweef is through which the artery will come out from the ascending aorta. So the right coronary artery arises from the anterior one, anterior aortic sinus of the ascending aorta, and just forwards between the pulmonary trunk and the right auricle of the right atrium. It ascends almost vertically in the right atrioventricular groove, and at the inferior border of the heart, it continues posteriorly along the atrioventricular groove, posterior atrioventricular groove to anastomose, to do some anastomosis, which is not, by the way, sufficient enough if one of the big vessels, the right or left or one of the big branches, being obstructed, to replace or to to do its function. I mean, because as we know, the coronary arteries are functional end arteries rather than anatomical ones, and we know by that, what is meant by that is this anastomosis is not enough if one of the big vessels is obstructed to do the job to give blood supply to the cardiac muscle. So both right and terminal branches of the left coronary artery are being anastomosing in there in the posterior interventricular groove. We are having mainly five branches of the right coronary artery. The first one, the right conus artery, which is supplying the anterior surface of the pulmonary conus or infundibulum of the right ventricle and the upper part of the anterior wall of the right ventricle. The, uh, the second branch is the anterior ventricular branch. Those are two or three and supply the anterior surface of the right ventricle. There is an artery, small artery, which is important still, is the marginal branch, is the largest branch and runs along the lower margin of the costal surface to reach the apex, but it is not mostly supplying the apex because the apex is mostly supplied by the left coronary artery, by the way. We'll mention this later. And number three is the posterior ventricular branches, and those are mostly two and supply the diaphragmatic surface of the right ventricle. Branch number four is the posterior interventricular descending artery, which runs towards the apex in the posterior interventricular groove. It gives off branches to the right and left ventricle, including its inferior wall. It supplies the branches to the posterior part of the ventricular septum, but not to the apical part, which receives its supply from the anterior interventricular branch of the left coronary artery. This is very important. If it is obstructed, you know what will be affected. You know, obstruction of one of the vessels means that part of the cardiac muscle will be affected, will be ischemic, will be infarcted, and it has its clinical implications. A large septal branch supplies the atrioventricular node. You see, AV node is being supplied by one branches of the right coronary artery. And by the way, the branches of the coronary artery which are supplying this conducting system, part of the conducting system of the heart, is known to cause if it is infarcted or blood supply being jeopardized to those conducting system stations, it might cause some sort of arrhythmia to the patient, and the patient who is having accordingly some obstruction to the right coronary artery. So we are expecting sometimes arrhythmias more on the left side. You know, both could be affected, but specifically to the right side, arrhythmias could be more. The last branch is the atrial branches, and those supply the anterior and lateral surfaces of the right atrium. One branch supplies the posterior surface of both the right and left atria. The artery of the SE node supplies the node and the right and left atria. You know, and here is this is the pacemaker of the heart. This is very important. If it is affected with blood supply to SE node, it means some sort of dysrhythmia could happen to this patient who is having blood supply jeopardy to the SE node, AV node, as in the previous branch. So affection could be there. In 35% of individual, it it arises from the left coronary artery. Yeah, some branches could differ from one patient to the another, but blood supply to the this atrial branches could come from the left coronary artery. Just to keep it in mind, clinically from the point of view, it's important. Uh, Coming to the second big coronary artery is the left coronary artery. Is larger than the right coronary artery, and it supplies the major part of the heart, including the great part of the left atrium, left ventricle, and the ventricular septum. You see, big part of the cardiac muscles being supplied by the left coronary artery. It arises from the left posterior aortic sinus. التجويف الثاني من ascending aorta, and this is the one is called the left the posterior aortic sinus of the ascending aorta, and passing forward between the pulmonary trunk and the left auricle. And just have a look on this diagram on the right and there. It is as if it is going from the, just posterior to the pulmonary trunk, really. It then enters the atrioventricular groove, the anterior one, and divides into two terminal branches and big branches, very significant branches, really. Number one is the anterior interventricular descending, or sometimes they are calling it LAD, left anterior descending artery, which a branch runs downwards in the anterior interventricular groove to the apex of the heart, supplying to the apex. So the apex is supplied by the left coronary artery through the anterior interventricular or descending artery. In most individual, it then passes around the apex of the heart to enter the posterior interventricular groove and anastomose with the terminal branches of the right coronary artery, as we mentioned before. In one third of individuals, it ends at the apex of the heart. There is a small left conus artery which is supplying the pulmonary conus, and still this is important. Number two, the second branch of the left coronary artery is the circumflex artery, very significant artery, really, is the same size as the anterior interventricular artery. It winds around the left margin of the heart in the atrioventricular groove. There is a left, marginal artery like there. In the right, there is a marginal artery still. On the left, there is a marginal artery still. A left marginal artery is large branch that supplies the left margin of the left ventricle down to the apex. Anterior ventricular and posterior ventricular branches supply the left ventricle. Atrial branches, some atrial branches are still uh, arising from this circumflex artery and supply the left atrium. Clinical importance is what is known as the anterior interventricular artery, the left anterior descending artery. It is called as LAD. Cardiologists like to call it LAD. On the in the echocardiography when it is being done, or angiography, let me say it, اللي بيسمى قسطرة القلب, when they are doing cardiac catheterization. It will go there. We shall talk about cardiac catheterization at the end of the day. And this anterior interventricular artery supplies, number one, the anterior part of the interventricular septum, number two, greater part of the left ventricle and part of the right ventricle, number three, part of the left bundle branch of Hess, uh, this is very important, really, and the importance of this anterior interventricular artery is being a cause of common site of myocardial infarction. Of course, any vessel of the coronaries or one of their branches could be affected by obstruction and causing the picture of myocardial infarction to the patient. There is some called, as we mentioned, there is anastomosis between the coronary artery and the right and left coronary arteries. And by the way, we are to know that. Look at what is written in the written here. Coronary arteries are functional end arteries and vessels whose terminal branches do anastomose with those of the adjacent arteries. This is general definition, by the way, for the anastom. But the caliber of the anastomosis isn't sufficient to keep the tissue alive if one of the arteries become blocked, and this is very important. So coronary arteries are end functional arteries. Anastomosis between the terminal branches of the right and left coronary arteries, this is called collateral circulation. Anyhow, anastomosis between terminal branches of arteries is called the collateral circulation anywhere, by the way, existing, but they are on the coronary, but they are usually not large enough to provide an adequate blood supply to the cardiac muscle. Should or if one of the large branches become blocked by a disease like atherosclerosis, by an embolus, could be blocked mainly by an embolus or by an atherosclerotic disease or some sort of spasm, sometimes for a longer time. A sudden block or one of the large branches of either coronary arteries usually leads to myocardial death, myocardial infarction. We call it MI. Although sometimes the collateral circulation, sometimes not common really, but sometimes still collateral circulation could be big enough to sustain the muscle and not to die as quick as possible. Yeah, what we has explained is the normal or typical circulation or branches of the coronary arteries. There are some a little bit of variations in the coronaries, and the coronary blood supply to the heart could occur, and the most common variation affect the blood supply to the diaphragmatic surface of both ventricles. And on that basis, we are calling it sometimes, if there is some variations, one of it is the right dominance, coronary dominance, or the left coronary artery dominance. The right dominance by that is meant the posterior interventricular artery is a large branch of the right coronary artery, and the right dominance is present in most individuals, which is reaching around 90%. But by the left dominance, the posterior interventricular artery is a branch of the circumflex, the posterior interventricular artery, which is usually coming from the right side. Here, it's a branch of the circumflex artery, which is coming from the left coronary artery, and this left predominance is 10%. That's to say, most of the blood supply is coming from the left coronary artery. Even the posterior interventricular will be a branch from the circumflex, which is a branch from the left coronary. This is important for the cardiologist when doing an angio cardiac cath or cardiac catheterization to see to delineate the coronaries in a better way. Let us have what has being explained, looking at the variations, like here in diagram to the left, A by A on the A side. Here, look at the right coronary artery, and here is the branches, and here the circumflex branch is a small one. It is not replacing the posterior interventricular. And this is, of course, this is by A on A. This is the posterior view of the heart showing the origin and distribution of the posterior interventricular artery, and this is called as the right dominance. By the left dominance on B here, still we are having the posterior surface of the heart, and it is showing the origin and distribution of the posterior interventricular artery and the left dominance. You see, the circumflex artery is giving the branches going to the posterior interventricular artery. It's a simple illustration, but it means significant thing. Always, the many problems of the heart. I'm talking now about C diagram. Disease of the heart are having relations to the two main diseases of the heart, big diseases, are the coronary blood supply diseases, or insult, let me call it, or the conducting system of the heart. So the relations between the conducting system or the stations of the heart and the blood supply is very important still, because it means a blood supply to the stations or the pathways of the conducting system of the heart. So this is an anterior view in C here, anterior view of the heart showing the relationship between the blood supply to the conducting system. And by relations, it means simply, blood supply to those stations of the blood of the conducting system of the heart, which have a clinical implication. Definitely, it must have. So, in summary, let us enumerate the branches of both the right and left coronary arteries. Branches of the right coronary artery are to all of the right ventricle, except for a small area to the right of the anterior interventricular groove. Number two, a variable part of the diagrammatic surface of the left ventricle. Number three, posterior one-third of the ventricular septum. Number four, right atrium and part of the left atrium to the right side. And number five is the SE node. Look at the blood supplying the SE node by the right coronary artery. EV node by the right coronary artery. This is very important. Left bundle branch, bundle of Hess, as we know. Atrioventricular bundle, left bundle branch, and a few smaller branch. And left bundle branch is this mostly, if it happens in a patient, it mostly can be pathological and have to be considered very serious in a patient who is having some chest pain or just being found incidentally or accidentally in the patient on an ECG finding electrocardiogram. For the branches of the left coronary artery, most of the left ventricle, the pump, the main pump machine of the heart, by the left coronary artery, a small area of the right ventricle to the right of the interventricular septum, anterior two-thirds of the ventricular septum, the main bulk of the heart muscle, really, most of the left atrium, then coming right bundle branch and left bundle branch. You know, both bundle branches are receiving blood supply from either the coronary and the right and left coronary arteries, specifically the left bundle branch being very significant still for everything. Contractility, I mean. The second type of blood supply to the heart is the venous drainage. Like any organ, this is an arterial blood going to the heart, and the venous drainage, after being pumping, the blood will be returned to the right atrium mainly to mix with the venous return from the inferior and superior vena cava to continue the circulation, and that the blood will go ultimately to the right to the right ventricle, then to the pulmonary trunk, to the lungs, from the lungs to the pulmonary artery, and so on. We shall talk about this circulation later on. But here, for the venous drainage of the heart, most of the blood from the heart will drain into the right atrium through the coronary sinus, as we have mentioned, which lies in the posterior, yeah, coronary sinus, where it lies. It lies in the posterior part of the atrioventricular groove and is continuous with the great cardiac vein. Ultimately, the coronary sinus will open into the right atrium to the left, just keep it in mind, to the left of the IVC or inferior vena cava. A small and middle cardiac veins and the tributaries of the coronary sinuses are there still, tributaries to the coronary sinus. The remainder of the blood is returned to the right atrium by anterior cardiac vein and by small veins that drain directly. Some of the veins are draining directly into the heart chambers whenever the drainage is there. Let us have this nice illustration. Really, the posterior surface of the heart is still, and looking, it's nice delineated. Tributaries of the coronary sinus are the great cardiac vein. Look at it, nicely looking, and the drainage in the posterior atrial, interventricular groove. Some of them, and some the coronary sinus is there in the atrioventricular groove. Tributaries of the coronary sinus are the great cardiac vein, number one, number middle cardiac vein, number three, small cardiac vein, posterior veins vein on the on of the left ventricle, and the drainage is there. Then the oblique vein of the left atrium. Those are nicely being illustrated. Just have a look. Posterior surface of the heart and giving the whole drainage to the, the coronary sinus. Coronary sinus itself, as we said, it opens in the right atrium, just at the opening of the inferior vena cava. For clinically, this blood supply and its distribution to the heart muscles or to some stations in the conducting system of the heart, it has great implications. As simple as that, let me express it. We have said the main diseases of the heart are simply jeopardy of the blood supply, either being obstructed suddenly, and obstruction suddenly was whether to the main stem of the right coronary or left coronary or one of its significant branches gives the picture of myocardial infarction, say, or angina. Myocardial infarction if sudden, or vaginal pain, on and off pains, cardiac chest pain. Clinical picture of myocardial infarction, please just keep it in mind. Number one is to keep the picture of the patients. Mostly those patients are predisposed to cardiac insults like heavy smoker, fair looking people, and by the age above 50 or even below that. No age, 30, 40, they could have, if there is disease in the coronary arteries, and the patient will be presented by some sort of retrosternal pain, and this pain could radiate to the left shoulder, to the jaws, or sometimes even to the epigastric area. Associating this pain is a picture of, as the patient could be nauseating, could be vomiting, could be sweating still, and he is having, there could be some dysrhythmia in the heart if the patient is one of the manifestations of the conducting system is being affected. And sometimes the patient could be present with some sort of certain block, or present with some dysrhythmia, or present with sudden death. Really, it could sudden death if massive occlusion to some of the coronaries, and we are to consider and respect that. The main cardiac pain we call it typical cardiac pain when radiating to the left shoulder and inner side of the of the upper of the arm, or the upper arm, let me call it. And this is referred pain because from embryological point of view, this is one dermatome, and the nerve, the somatic nerve, will be through the second thoracic nerve, which is supplying the area of the heart muscles, and this distribution of this nerve to the inner side of the left arm, and the area of the axilla. This is the nerve supply of the second intercostal nerve, intercostal brachial nerve, we call it. And this is very important. This is referred pain for that area. The epigastric pain, is still having its own significance, as if it is epigastric pain, especially if the posterior surface of the heart is being affected. And this is again a specific pain being more or less supplied by the same dermatome. And this is more or less is having an embryological basis to explain such a referred pain. This is very important. Myocardial infarction is fairly an emergency status. Patient had to be to the hospital. We diagnosed that by the clinical picture, by doing an ECG to the patient, an echocardiogram, and most important, to give some course. Yes, sometimes we are giving some aspirin, some analgesics like morphia, and to treat that, sometimes we are doing some sort of uh, cardiac catheterization if feasible in the same hospital, or to give some drugs to dilute such an embolus or such a thrombus in one of the coronary arteries or one of their big branches, or to solve it and to resolve the picture. Here, this is just a table to show if you are interested, and if you wish just to have a look on it. Yes, it is not you are not requested by this in the second year just to have it, but it's important to know that the main arteries or their big branches being blocked, the common branch, like the proximal, as it has been mentioned, this proximal left anterior descending artery, the anterior interventricular artery. And there is an ST elevation by the ECG, which we have explained earlier. There are some manifestations in that. And what will be affected is the large anterior wall. It's affecting the main big muscle of the heart, the pump of the heart, which could put the patient in a problem. The other one, this is the proximal. Coming to the more is the distal, coming the left coronary artery or right coronary artery at the end of the table here, right ventricular, usually the inferior one, and there are some manifestations in the ECG. Just have a look and try to read it, just to widen your knowledge and expand it in a way or another. It's very interesting. The main stations, the main arteries being affected by this slide, actually, by this slide is very important and very critical one to know the surface anatomy of the heart valves or to know the auscultatory areas of the heart. And this is very important to look in this diagram and to know just on the left to read and to master this. Very nice. Because by your stethoscope, if you are to auscultate the heart, where to put your stethoscope in which areas? If you are going to try, and whenever, by the way, going to auscultate the heart, we are to auscultate the four areas in the heart. We must auscultate the four cusps because each cusp might have a problem like being stenosed, like being in regurgitation or incompetence, and to diagnose which disease we are having in this patient. So in the tricuspid valve, where to auscultate the tricuspid valve? Tricuspid valve lies behind the right half of the sternum, opposite the fourth intercostal space. Very important to know each word of this definition. Where is the mitral valve? The mitral valve lies behind the left half of the sternum, opposite the fourth costal cartilage. So there is one to the right and one to the left, and better to know this very well. No choice except to know this perfect. And coming now to the pulmonary valve. Pulmonary valve lies behind the medial end of the third left costalis cartilage and the adjacent part of the sternum. But the aortic valve lies behind the left half of the sternum opposite the third intercostal space. And those are the auscultatory areas of the heart. It's a must. You have to know them by heart. You are to practice them during. It's a skill to be gained. Where to auscultate the heart, and this is very important for all physicians to come and this is the picture of some cardiac catheterization. By cardiac catheterization, or it has been called قسطرة القلب. How we are doing this? We are introducing a catheter with a guide wire in one of the big veins, like the femoral vein. What usually the veins being, or arteries, sorry, or the arteries, of course. Cardiac catheterization is an arterial approach. The arterial approach, either the femoral artery in the thigh, on the right or on the left, or the radial artery in the forearm. And by that, there is a guide wire and there is a catheter. By reaching the area of the coronaries, we are injecting a dye, radio opaque dye, so as to delineate the vessels, as could be shown in here. In the uppermost one, on the right side, if we are looking at the big vessel, there is a stenosis area. All the artery is going very smooth, and at the middle, there is some sort of constriction. Here on the left, which is written on by yellow, there is a smooth artery, and just there is some sort of constriction in here. So we are diagnosing by this, by this catheterization. There is a radio opaque delineation of the coronaries, which part of the coronary is being affected, and we are diagnosing that. We could open this by which is called as nitrogen stenosis of the artery in here, and just by some sort, could be by an atherosclerotic patch to the right, or putting a stent. Opening this stenosis could be by some sort of coronary angioplasty, just dilating the area with some dilatation balloon putting in that area, or putting a stent. According to the type of the stent, it will give the blood the chance to go from proximal to the distal part of the cardiac muscle, which is very important, very essential, very helpful to the patient, and need the skill. It's very nice. The advance in cardiology nowadays is through this interventional catheterization and putting good stents. It's rewarding. If we cannot do this, there will be some sort of open heart surgery, And by heart surgery, we are doing some sort of cabbage operation. And by cabbage is meant coronary artery bypass operation, like as if we are creating a bridge, just proximal and distal to the stenotic area. We are putting a vein graft on arterial graft from the internal mammary artery, which is very, this is one way and that's another way. But by cardiac catheterization and putting a stent or doing an angioplasty is fairly rewarding to the patient. And after the procedure, the patient will be put on anticoagulants and follow up in a nice by the cardiologist. Auscultation of the heart, as we have mentioned, we are having two sounds, the lub dub. You remember the lub dub is one and is two. The first heart sound is produced by, again, I am repeating this really, by the contraction of the ventricles and the closure of the mitral, followed by the tricuspid valve. The second heart sound is produced by the sharp closure, again, closure of the aortic and pulmonary valve. Auscultatory areas, tricuspid is best here over the right half of the lower end of the body of the sternum. This is clinically speaking now. Mitral valve is best here over the apex beat and is at the level of the fifth left intercostal space, 3.5 inches or 9 centimeters, as we mentioned earlier in our, anatomical locus of the apex from the midline. The pulmonary valve is here with the least interference over the middle end of the second left intercostal space, and the aortic valve is best here over the middle end of the second right intercostal space. This is very important illustration. Knowing this, the position of the valves and where to auscultate is very important and critical to know. Here we are to mention to finish this lecture. This is the last slide. To know the valvular diseases, which we have to mention really, whereas we mentioned the auscultatory areas of the heart as a clinical assessment for the patient, whatever the disease is having. The diseases of the heart are mainly those diseases related to the coronaries of blood supply, arterial blood supply mainly, and coming to the valves. This is apart from some other diseases of the myocardial muscles like myxoma, like, any neoplasm or something coming from the heart muscles like any other organ. But for the valvular diseases of the heart, there is the cusps of each valve could be affected by all the valves, could be affected by inflammation of a valve, can cause the edges of the valve cusps to stick together, and they are sticking together. This will lead some sort, if this is inflammatory process, there will be fibrous thickening of the cusps themselves or the rings being affected, followed by loss of flexibility and the shrinkage of the valves. And secondary to that, there will be some sort of narrowing or stenosis of the in between the cusp, and there will be stenosis of the valve itself. We are calling that. We are calling mitral stenosis, aortic stenosis, pulmonary stenosis, tricuspid. All this could happen to the valves, or the valvular incompetence or regurg. If they cannot be co-opted together or close together, there will be turbulence of the blood going and coming, and this is called as incompetence and regurgitation of the valve. Aortic regurg, mitral regurg, pulmonary regurg, tricuspid regurg. So stenosis or regurg could be used for either for any of the valves of the heart. Then the heart ceases doing the proper or efficient pump or function of that part of that valve itself. It has its own clinical presentations, implications, and management even. A good example for the valvular disease of the heart in the younger age group, we are having the rheumatic heart disease of the mitral valve, say, for example, which not only do the cusps undergo fibrosis and shrinkage, but also the chordae tendineae. The chordae tendineae, for which are connecting the cusps to the papillary muscles, and doing the proper function. Chordae tendineae are being shortened, being fibrosed, preventing closure of the cusps during the ventricular systole, and manifestation, if any of those valves being affected, there is certain presentations for the patients. The other type of the valvular diseases, which is, of course, we agreed that either stenosis or regurgitation of any of the valves, but there are some murmurs on the heart. Those are represented stenosis or regurgitation. What is there? A presentation in the patient, it will be shown to the patient or manifested in the patient by some sort of murmurs and the specific murmur. So if an example for that, if we are having mitral regurg, we are having what is known as uh, pansystolic, soft pansystolic murmur and radiating to the axilla. This is very typical. If we are having mitral stenosis, we are having some sort or rumbling murmur on auscultating the mitral area or the apex of the heart. A rippling effect. So a rippling effect would be set up leading to turbulence, turbulence of the blood coming and going, turbulence of the blood, not the perfect pathway, and vibrations, vibrations for in one of each valves, and expressions for that that are heard as heart murmurs. Thanks a lot. Just to me, and I hope we explained the things in a clear way. It needs to be read once, twice, thrice, and to be guided by your textbook. The best of luck to you, and please, for any question, I am ready anytime and by any. Thank you very much.